bit about neonatal physiology. We should remember that all babies are born with excessive total body water. And after birth, there is efflux of fluid from intracellular fluid to extracellular fluid. And this floods the neonatal kidneys, which result in salt and water diuresis over the first 48 to 72 hours of birth. And this loss results in physiological loss of weight in the first week of life. It could be as high as 10% for term, and for preterm it could be even 15% of their birth weight. Now we should remember that this extra cellular water compartment, which is larger in neonates, has got dosing implications when we decide upon the doses of the drugs that are to be administered. So the amount of insensible water is inversely proportional to the gestational age. The younger and the more physiologically the immature the infant, the higher is the skin permeability and also the ratio of body surface area to weight, and as well as the metabolic demand. And as a result, their fluid requirement is also higher. Again, the use of radiant warmers and phototherapy, which is very common in sick children, they all increase the insensible water loss. Preservation of body weight with warming devices reduces this insensible water loss. Now you should remember that insensible water loss is more when the body temperature is raised. It is as high as 30% per degree rise in temperature. When the ambient temperature is high, again, from the higher the ambient temperature, higher is the insensible water loss. Increased respiratory rate, increased motor activity, like when the baby is crying too much, there's a lot of insensible water loss. Regarding glucose metabolism, we should remember that the glycogen storage as well as gluconeogenesis both develop during the later part of the gestation. So the babies which are born premature, these two functions are often deficient. So they need a constant supply of glucose. Neonates and infants, they need glucose in their IV fluid. And children up to 5 years of age do need glucose, but the amount of glucose they need decreases with the increasing age. And after 5 years, they no longer need any glucose in their perioperative fluid. Regarding role of colloid, only a few words. We should remember that the capillary permeability to proteins is increased during the early stages of development, and it is further increased in disease states. And so the very young premature infants born premature, or in the even the mature infants in their early days of life, they have their capillaries are highly permeable to the colloids, particularly the albumin. So if albumin is administered to these children, to the sick neonates, then it is possible that the albumin will leak out to the capillaries. And these leaked out albumin will cause interstitial edema. Instead of increasing the intravascular volume which you want, they will leak out and cause edema in the interstitium, which will further, and it will pull out water from the intravascular volume. So it will further deplete the intravascular volume and it will impair tissue perfusion. So albumin as a colloid will do more harm than good. Now the aims of perioperative fluid therapy is slightly different in NICU and intraoperative. In NICU, it is usually to maintain the electrolyte balance, provide adequate nutrition, and limit fluid overflow. But intraoperatively, fluids are administered to maintain hemodynamic stability, because we know that during anesthesia, all anesthetics, they are vasodilators, they are also myocardial depressants. And so to maintain hemodynamic stability, we need to give fluid. We need to replace the potentially massive evaporative losses, because in abdominal surgeries, there is a lot of raw areas, and restoration of circulating blood volume after heart space accumulation or blood loss. But again, this has to be balanced with the need to prevent overhydration, because overhydration causes pulmonary edema prolonged ductal patency, then lung deterioration, and neonatal enterocolitis. The usual method of calculating fluid, we all know the Holiday-Segar method, less than 10 kg, up to 10 kg body weight, 4 ml per kg, 10 to 20, it is 2 ml per kg, and about 20, we add 1 ml per kg, 260 ml. That we know. We will not go into the details here. But what is more important is that when we plan to administer some fluid to a pediatric patient intraoperatively, we should remember that it's not one component that we are going to replace. There are 3 components. And it is important, we'll come to the next slide. These 3 components are, first is the maintenance, that is the maintenance of water and electrolytes to cover the insensible and urinary losses. The second is replacement of pre-existing deficits because of prolonged nil orally status or excessive losses, like patient could be having vomiting, patient could be having GI losses with a rise tube on drain, or replacement of ongoing losses because of exposure to the warm environment of the OT, because of the surgical blood losses and sequestration of the fluid in the third space. And so it is important to know the defined components, because the replacement fluid for the different components are different, and because the fluid that we lose from different spaces are also different. What we lose as blood, that fluid is different from what we lose from the GI tract or from the what is sequestered in the third space. They are all different. So their replacement is also different. They have to be replaced by different fluid. And calculation of volume is also different. Maintenance fluid calculation is different from what is calculated for replacing the third space loss, like that. And fluid should always be administered by burette, or still better, a syringe pump, so that an accurate amount of volume of fluid can be administered. And even if we are giving by burette, we should not fill it the entire 100 ml. We should, if the infant is very small weight, then we should only fill say 20 or 30 ml or 50 ml. So that even if by mistake it stays open, patient will get a bolus of only 20 to 30 ml, not the entire 100 ml. Now, coming to the different components, first is the maintenance. Maintenance water electrolytes is given to cover the insensible and urinary losses, and it is the amount of it is used to cover the amount of water lost during basal metabolism, and we know that it is calculated by the Holiday-Segar formula, which we are all 4-to-1 formula, which you are all aware of. And this maintenance fluid is usually maintained by hypotonic maintenance fluid. Hypotonic maintenance fluid, but it should contain dextrose. And again, as I have told, that even when very small immature infants or neonates up to first 2 days of life, they need around 10% of dextrose, and gradually as the child grows and as we get bigger and bigger child till 5 years, we can come down from 10% to 5% to even 1%. And many use balanced salt solutions, but here also we need to add additional dextrose. Now, replacement of pre-existing deficits, and this deficit usually occur because of the NPO status. We should calculate the deficit volume for NPO, number of hours the patient was kept nil already. By the for every hour we can calculate the 4-2 by the Holiday-Segar method, and then multiply it with the number of the hours the patient was kept NPO. And the total volume that is calculated, half of this volume is usually replaced in the first hour of surgery, and the next half is replaced in the subsequent 2 hours. That means 1/4 in the second hour and 1/4 in the third hour. Now, if you have followed the ASA fasting guidelines scrupulously, then there is no need to replace this deficit. You would remember that according to ASA fasting guidelines, the child is allowed clear fluids till 2 hours of surgery and breastfeeding till 4 hours of surgery. So if you have followed that, adequately, then this important component can be very well done away with. Next is the replacement of the pre-existing deficits. Pre-existing deficits may arise because of the vomiting, diarrhea, sequestration of third space, for example, in cases of peritonitis. Now, regarding third space loss, it is defined as surgical trauma to cell membranes causing hypoxic injury, creating a capillary leak, resulting in extravasation of isotonic protein-containing fluid into interstitial compartment. This is called the third space. Although recently there have been a lot of debate on this, and some experts believe that there's nothing called third space loss. As of now, we'll continue with this concept, which we have been taught in for years together. And this third space loss is usually corrected by balanced salt solution or normal saline. It should never be corrected by hypotonic fluid. And it depends on mild, moderate, or the severe tissue trauma, depending upon the how much is the tissue trauma, depending on the surgery. And it can be, fluid replacement may be done with 3 to 4 ml per kg per hour if it is mild, 5 to 7 ml per kg per hour if it is moderate, or more than 10 ml per kg per hour if there is severe tissue trauma, like dissection anastomosis of a perforated intestine. Replacement of pre-existing deficits, it is because of the ongoing losses. If it is blood, if there is blood loss, then we have to replace it with equal volume of autologous blood or crystalloid in the ratio of 1:2.5 times. Third space loss, as we have already discussed, it is fluid loss from extracellular fluid compartment, and it is high in sodium and chloride and low in potassium, bicarbonate and calcium. So it is replaced by balanced salt solution or with lactate or acetate, or it is either replaced by balanced salt solution containing lactate or acetate, because this lactate or acetate gets degraded into bicarbonate, which acts as a buffer and prevents metabolic acidosis. Normal saline may be used to correct this deficit, but we should remember that it might cause hyperchloremic acidosis. A few words about glucose in intraoperative period, intraoperative fluid. Although we have discussed that pediatric patients up to 5 years of age do need glucose in the maintenance fluid, with higher glucose as the child is very young and decreases with the older child. We should also remember that hypo and hyperglycemia both are detrimental. Neonates need glucose in the maintenance fluid, and after 5 years, glucose-free isotonic solution is adequate. Glucose-containing solutions should not be used to replace intraoperative fluid loss. And there's a very important caveat for my younger colleagues. If any pediatric patient at the end of surgery is not waking up, always do a glucose check. So to summarize the intraoperative fluid therapy for pediatric cases, so infants up to 3 months, where you find that there is risk of hypoglycemia. Why? Because the patient was NPO for a long time, or for other reasons, patient was not taking adequately, very sick children not taking adequately. In those patients, dextrose 5% normal saline or balanced salt solution may be used. For replacement of losses, balanced salt solution. Infants more than 3 months, not much of risk of hypoglycemia, because the patient was otherwise healthy and was allowed fluid till 2 hours as per the ASA fasting guidelines, and the surgery is minor, or it could be a major surgery also. Then for maintenance, we can use low dextrose balanced salt solution. Low dextrose means around 1% of dextrose, or you can use any of the balanced salt solution. Infants more than 3 months and again has got risk of hypoglycemia, again because patient was not taking orally, was not allowed to take orally, or very sick. In those patients, we can use balanced salt solution, but with 2.5% to 5% of dextrose. 1 year to 5 years, yes, low dextrose, that is 1% dextrose with balanced salt solution or ringas lactate. More than 5 years, balanced salt solution. And for replacement of losses, in all the cases should be with balanced salt solutions. Thank you.